Okay. Hi, my name is Jillian, and this is Stephanie over here, and today we're going to talk about updates in the treatment of depression and bipolar. And one of the reasons why I thought this was a good topic was because I came to this institution never really dealing with many psych patients, and when I came, all of a sudden I was looking at all their orders. So I figured that it was going to be a good refresher for me, and I thought that we could all kind of use a refresher on what agents are available now and what's in the pipeline. So here are our objectives. First, we're going to talk about depression, and then we're going to go into bipolar. So hopefully we can talk about both. And we have nothing to disclose. All right, so major depressive disorder. So unfortunately, this may not be off if we were to be attacked by a bunch of monsters. So there's a study published in JAMA in 2017 that looked at how many patients actually receive antidepressants. In the United States, there's 12% of people have actually gotten a prescription filled for an antidepressant in the past year. So they're widely used, obviously, for things other than just depression, but it highlights what a big issue this is in our country and in the world in general. It's one of the most common mental health disorders. Over 300 million people worldwide are diagnosed with major depressive disorder every year. And unfortunately, there's been an increase up to 18% between 2005 and 2015. I would like to think that we've gotten a lot better at diagnosing depression, and that's why, but I think it's multifactorial, and potentially that doesn't account for the whole 18%. And sadly, 800,000 people per year die from suicide. It's the 10th leading cause of death in the country. And it's the second leading cause of death in patients aged 15 to 29 years old. So it really impacts all of us, and I think it's something that we need to focus and assess our patients for. In 2015, it was estimated that 16.1 million Americans, or 6.7% of Americans, actually had at least one episode of major depressive disorder. And when we evaluate the prevalence in the general patient population, it's about 6.7%, so anywhere from 5 to 10% overall is what they saw. But when we're dealing with our patients, they have a lot of other reasons to have even higher rates of depression related to this. There was a study done in patients with COPD and CHF, and they saw a prevalence of about 20 to 30% compared to the 6.7%. When you evaluate patients who have potentially organic causes such as traumatic brain injury, hypothyroid, other things like that, the prevalence could be even higher than that. So it's definitely something that we should be looking out for and assessing in our patients. So how do we diagnose major depressive disorder? Well, it's typically a period of 2 weeks or longer with either a depressed mood or a loss of interest. The difference between depression and sadness or stress is that it lasts way beyond what the normal amount of time would be to recover from things like that. And then patients also have to have at least 4 symptoms that reflect a change in functioning. So this can be fatigue, worthlessness, changes in sleep habits or appetite, an inability to concentrate, etc. I could spend the next 3 hours talking about the pathophysiology of depression, and unfortunately, still actually very little is really known about what is going on in our brains to cause patients to be depressed. There are a few theories that I just wanted to highlight, the first one being monoamine deficiency. So this was a theory that came out back in the 1950s and 60s. The original thought was that depression was due to decreased brain levels of norepinephrine, serotonin, and dopamine. But it's much more complex than that, involving a lot of different inhibitors and other things like that. But again, it would take me a long time to describe, so I'm going to keep it at that. Genetics is thought to play a role, but not nearly as big of a role as other psychiatric disorders such as bipolar and schizophrenia. When they evaluated twins, they saw that there was an incidence of both twins being diagnosed with major depressive disorder about 37% of the time, whereas things like bipolar and schizophrenia, the incidence is much higher. There is a thought that potentially stress plays a role. In patients that have had elevated cortisol levels, they've actually also seen an increased risk of major depressive disorder, which I think makes sense because as patients' bodies are stressed, then they can also have an increased incidence of major depressive disorder. And there are a slew of other potential mechanisms for why patients get depressed. Unfortunately, the last time that the guidelines have been published was in 2010. They break down treatment into 3 different phases. First, you have your acute phase, and really the whole purpose of the acute phase is to induce remission in patients. In the case of mild to moderate disease, they typically will recommend that patients either get an antidepressant plus or minus psychotherapy, or in certain cases when patients have certain disease states, and they'll also get, in certain cases when patients are psychotic or catatonic, then you'd also, this is a case where you potentially would do electroconvulsive therapy up front. When patients do not achieve remission after several trials of antidepressants and you've assessed that they've gotten to their maximum dose, then this would be a consideration. The antidepressants that the 2010 guidelines recommend using are either SSRIs, SNRIs, mirtazapine, or bupropion. They also do mention tricyclics, monoamine, MAOIs, or trazodone as well, but the recommendation isn't as high for their use due to a number of factors, but mainly because of side effects. If a patient doesn't achieve remission after using one of these drugs for 4 to 8 weeks, then you'll use another agent, and that's what the recommendation says. From there, there's usually a continuation phase. So patients are then treated for 2 to 9 months, plus or minus psychotherapy. If they're responsive to ECT, then you're going to continue that. Usually you do about 12 cycles of ECT with patients. And then finally, you may be able to titrate patients off of their antidepressant if their disease is mild to moderate. But in the case of really severe disease, or if a patient has failed several agents, you may want to continue their antidepressant treatment, and you're going to continue at the full therapeutic dose and consider psychotherapy. So really quick, I wanted to highlight, since I mentioned that there are many different agents out there. When we talk about SSRIs or SNRIs, all of the drugs are different, and so they're going to have a different profile, even just looking individually in a class of medications. That's why it's easy to switch from one drug to the other and trial different agents. So the main mechanism for all of these SSRIs is really to bind to the SERT transporter and prevent reuptake of serotonin. However, there are a lot of secondary effects that we don't always consider when we're looking at these drugs. And it's important to look at these effects because over 50% of patients will discontinue drugs due to their side effects. So it's important that we're tailoring therapy to the patients. In the case of citalopram and escitalopram, these are the most selective for serotonin, but they also have a higher affinity for histamine receptors. So you have to worry about weight gain, nausea, and sexual dysfunction. With fluoxetine, you get an increased binding to the dopamine receptor as well as modulation of your norepinephrine and dopamine receptors. So this may be really good for patients who are lacking energy because there's an increase in activation. Paroxetine has some muscarinic effects. So it has the highest risk of anticholinergic side effects out of any of the SSRIs, but it also has benefit in patients who are having trouble sleeping. And then if you evaluate sertraline, it's got the highest risk of cardiovascular, extrapyramidal symptoms, and sexual dysfunction due to its increased effects on dopamine. So I'm not going to go through all of these, but I did want to highlight the differences between the two serotonin norepinephrine reuptake inhibitors. Often on medicine, one of the issues that I come across is that a patient can no longer swallow their duloxetine capsules, so we end up switching them to venlafaxine, which isn't always the greatest thing because they're two different agents. Venlafaxine, especially at doses less than 150 milligrams, is a pure SSRI, whereas duloxetine has equal norepinephrine and serotonin activity. I called the manufacturer one time because I was wondering, what should we do in these cases where a patient is on duloxetine and can no longer swallow it. And they gave me this long sheet that has all of this information on it, but really just to paraphrase what they said that you can actually open the enteric-coated capsules and put it in water or apple juice, but they would recommend anything with a pH of greater than 6.6 is what they said because it degrades the capsule. So you could never put it in something like pudding is what they recommended. The other thing that they said is that you really should never be putting these drugs through an NG tube, and they showed me pictures of the NG tube clogged. So I don't know that we have a great answer for what we should do with our patients who can't use duloxetine through an NG tube, but potentially if they can swallow, just not the capsule, then you can consider mixing it with water. Bupropion is unique just because it doesn't have any effect on serotonin, and therefore it may actually be appropriate for patients with psychotic disorders, which the other agents aren't. The big issue with bupropion is its risk of seizures, and they actually put in their package insert that it's contraindicated in anorexia and bulimia because they did see an increased risk of seizures. Things that you could do to avoid that include increasing doses greater than 450 milligrams per day or rapidly titrating it. And then finally, I wanted to highlight mirtazapine. I see that we use it a lot in the hospital for sleep. The really important thing about mirtazapine is that it does have a high affinity for histamine receptors, but only at doses less than or equal to 15 milligrams. So a lot of times I'll see our providers go way above that for sleep, and you wonder what the benefit would actually be of doing that. So just something to watch out for. There's also some non-pharmacologic therapies that I just wanted to review really quickly. Psychotherapy is a cornerstone to potentially treating major depressive disorder. Cognitive behavioral therapy is probably the type of therapy that's been used the most frequently and has the most data supporting it. I touched on electroconvulsive therapy, but this is still probably one of the most effective methods that we have of treating multi-drug resistant major depressive disorder. So it's always something that we should consider in our patients. The obvious issues associated with it is that it's very invasive, it requires sedation, and it can be difficult for patients to get. One of the newer therapies that is actually recommended in the 2010 guidelines, well, not recommended, but suggested in the 2010 guidelines is transcranial magnetic stimulation therapy. And basically what is done, and it's funny because I hear these commercials all over the radio talking about it, but it's, so RTMS therapy is really what I've seen a lot of, and it's repetitive transcranial magnetic stimulation therapy. Basically what they do is they apply a magnet over a patient's prefrontal cortex, and they induce a magnetic field that results in depolarization of underlying neurons. The issue with this is that there are many different ways that this can be done and applied to different parts of the brain, and unfortunately there was a study done in JAMA in 2017, and really there is little to no benefit in doing this in most of the ways that it's been shown to be done. So the other issue with this is that it's very expensive. So it's around $6,000 to $12,000 for around 20 sessions. So it can be really expensive with really small to moderate benefit. And the final one that we see, and I haven't seen this frequently, but they will do vagus nerve stimulation. I think this was first studied in patients with seizures, but they have seen a benefit in depression. Basically what they do is they apply this electrode, and they have a stimulator lead going into your vagus nerve and stimulating, depolarizing the neurons around the vagus nerve. And again, this is really invasive, so it's not something that we can use frequently. So why exactly are so many new treatments necessary? Well, in 2006 in the Journal of Clinical Psychiatry, they showed that about 50% of patients don't respond to treatment, and 2/3 will fail to achieve remission. So we're not doing great as far as treating major depressive disorder goes. So today I'm going to talk about the updates. Before we get started, I just wanted to highlight two of the scales that are typically used to assess pharmacotherapy agents. The first is the Hamilton Depression Rating Scale. It's a 17-item assessment. It can be either 17 or 24 items. In the case of the studies that we're going to see today, it's 17. You score between 0 or greater or equal to 23, and each of the scoring blocks kind of tells you where you are as far as 0 is having no depression and greater than 23 is very severe depression. This has a wider assessment of physical symptoms, so it'll assess things such as weight loss and other things like that. The Montgomery-Asberg Depression Rating Scale is a 10-item assessment, and the scoring is 0 to 60, with greater than 34 being severe depression. So what other non-pharmacologic updates do we have so far? Well, one of the newer therapies is dialectical behavioral therapy that's kind of been shown to be just as effective as cognitive behavioral therapy. I'm not going to go into detail with this because I want to get to the drugs, but just something to keep in mind and to look out for in your patients. The other type of therapy that's non-pharm is a transcranial electrical direct current therapy, or TDCS. And this is slightly cheaper than the magnetic therapy that I described before. Basically what they do is they put an electrode on your dorsolateral prefrontal cortex, and they stimulate the neurons below where they put the electrodes. And so this is a newer therapy. It's a lot cheaper and doesn't necessarily come with the same side effects. They did a New England Journal of Medicine study earlier this year where they looked at using the electrical direct current therapy compared to escitalopram. And basically, I'm not going to go through all the details of the study, but they could not claim that TDCS therapy was equivalent to escitalopram, but it was greater than placebo. It was clinically better than placebo. So there are three major drugs that have come up that I wanted to highlight really quickly. The first is Vilazodone. This is a combination of a SSRI and a partial 5-HT1A agonist. And basically the way that the 5-HT1A agonist works is it facilitates the desensitization of the presynaptic 5-HT1A autoreceptors. It's the same mechanism used in the drug Buspar or buspirone. And so it's believed that by combining the SSRI activity with this activity, then potentially the onset of action would be quicker, and it may also help with patients who have anxiety associated with their depression. The target dose is 20 to 40 milligrams, and most of the studies that saw efficacy saw it at 40 milligrams. There are dose adjustments associated with CYP3A4 drug interactions, so you do have to watch out for those. It's got a low potential for cardiac issues, And again, it might be really good with concomitant generalized anxiety disorders. One of the studies that looked at this was a double-blind randomized controlled trial in the United States that evaluated 500 patients. And the patients had to have major depressive disorder for greater or equal to 8 months or less than 12 months. The patients could have generalized anxiety, social anxiety, and phobias, but they could not have any psychotic type issues. And they followed the patients for 8 weeks with a 1-week taper. And as you can see, so on the x-axis I have weeks, and on the y-axis this is a change in their Montgomery score. And you can see that the change was statistically significant and really started happening at around week 4. So potentially this is a viable option for for major depressive disorder. They also did a post hoc analysis, and they noticed that there was also a statistically significant higher rate of remission associated with Vilazodone compared to other drugs. As far as side effects go, it's all related to serotonin. So the patients get a lot of diarrhea, nausea, dizziness, and insomnia, which is almost what would be expected. There were no severe side effects seen in this study, but again, it was only 8 weeks, so I'd like to see what the drug would do for a further period of time. The next drug that I'm going to talk about is vortioxetine. This has SSRI action. It also is a 5-HT1A agonist and a 5-HT3, 1D, and HT7 antagonist, which all work in modulating serotonin, norepinephrine, and dopamine. It's indicated for the treatment of major depressive disorder, and the target dose is going to be 20 milligrams. It's a CYP2D6 substrate, so you have to worry about drug interactions with that. It may be good, again, for patients with concomitant generalized anxiety disorder, and they've actually done studies that are coming out now associated with that. There was a randomized double-blind duloxetine reference study, so in the past drug there has never been any clinical trials where they've actually evaluated the drug to another SS or SNRI. They looked at 614 patients. And really what they saw, again, they used the Montgomery Depression Scale rating. And on the x-axis you have the study visit, which is also the weeks. And on the y-axis you have the change in the major depressive scoring. And what you'll notice is that the effect is not, so the purple line is going to be duloxetine. So at week 8, basically what they saw is that vortioxetine and duloxetine versus placebo were both statistically significant reductions versus vortioxetine at 15 milligrams did not see a reduction. And there was another trial that looked at 10 milligrams and 20 milligrams, and again, the 10 milligram didn't work. So you really might have to push the dose up to the highest amount to get the full effect. Interestingly, when you compare the 15 milligram and the 20 milligram doses, there weren't many differences in the side effect profiles between the drugs. They were fairly similar. So potentially hitting 20 milligrams is what I would recommend if you're going to use this drug. I still question the efficacy of it at lower doses. The final drug I'm going to talk about is Levominacipran. This is the S enantiomer of milnacipran, which is indicated for pain. This is a serotonin norepinephrine reuptake inhibitor, and the uniqueness about this drug is that it actually works twofold greater on the norepinephrine inhibition than it does the serotonin inhibition. So it also has no affinity for any additional agents. The unique thing about this drug that you must consider is the fact that it does interact with alcohol. When patients drink alcohol with it, they saw an accelerated drug release. So this is not an appropriate drug for a patient who drinks a lot of alcohol. You can take it without regard of meals, and it may worsen hypertension and tachycardia. And I guess that's what I was most concerned about because there was such a binding effect on norepinephrine. So this is just pulled from the package insert. What I would want you to just highlight is the upward shifts in hypertensive, the last line there. There was a significant difference between patients who were on placebo compared to those that were on the drug who went from normal or pre-hypertensive to stage 1 or stage 2 hypertension. So if a patient has underlying hypertension, this is definitely not an agent that I would recommend. Okay, so now I have a few questions. KS is a 39-year-old female with a past medical history significant for alcohol abuse and anorexia. The patient has normal kidney and liver function, and the team wants to start the patient on an antidepressant to treat underlying major depressive disorder with anxiety. Which of the following drugs would you recommend? So first we have A, bupropion, B, Vilazodone, C, Levominacipran, or D, encourage the team to consider TDCS in this patient. Yep, that's the right answer. So bupropion is not recommended in patients with anorexia or bulimia. And then because the patient drinks so much, levominacipran would not be an acceptable answer. And unfortunately, TDCS therapy has not been proven to be equivalent to drug therapy at this time. Okay, so the team starts KS on Vilazodone 10 milligrams daily. What would be an important counseling point? And unfortunately, I don't know that I mentioned it. Anyone have any ideas? This is important. Yes. So Vilazodone does need to be taken with food. When they compared it on fasting state versus when a patient was taking it on food, the bioavailability was 70% with food and about 50% when patients were fasting. So it's really important that you educate patients to take this medication with food. And if you see it on the floor, you're verifying orders, maybe just make sure that it's with a meal. Okay, which of the following is true regarding the mechanism of action of levominacipran? Any idea? Yep, let's see. So again, it works, unlike the other serotonin norepinephrine reuptake inhibitors, it works more strongly by inhibiting the reuptake of norepinephrine than serotonin. Okay, so what about the case of treatment-resistant MDD? So again, electroconvulsive therapy is probably our best option that we currently have, but there are some issues associated with it. There are also some augmentation strategies that have been considered and studied in the past. Those include lithium, buspar, and atypical antipsychotics. Brexpiprazole is probably the newest atypical antipsychotic that now has approval for augmentation in depression. So these are the other agents that currently have FDA approval, but these are all of them up here. And then what about ketamine? So ketamine has been getting a lot of press recently. In June of this year, the American Psychiatric Association put out a statement saying that although there's been great results and there have been really good trials that have been done, there's not enough evidence at this time for them to support it. And I think right now, hopefully in the future, we'll see more studies related to ketamine. The way that it's been studied in the case of major depressive disorder is usually they'll do a dose of 0.5 mg per kg, and they do the infusion over 40 minutes. So it's a lot different than in our pain patients that we're treating for several days. This is really kind of how it's been studied, and they'll do this for 2 to 3 times weekly. The unfortunate thing is that the studies, although they've been shown a large benefit in patients, they've been very small, and there hasn't been any, they've been small, but there have been randomized controlled trials. Also, because they're looking at usually around like 15 days is what they evaluate the efficacy to be, there's really not much safety data currently available. But I think there's more to come. There's also an oral ketamine product. So ketamine has poor bioavailability. We still do use it sometimes, but there is an oral ketamine-like product right now in phase 3 trials that's being evaluated. So I'm excited to see what the data is to support that. In November of this year, there is a JAMA review article that came out basically highlighting the new hope for treatment with ketamine. But again, it also mentioned that the data is limited at this time, but I am interested to see what ends up happening with it. Okay. Anyone, do you want to go? It's your turn.
Jillian and I were possibly a little overambitious to think that we would cover updates in both disease states in one session, but we're going to try our best, so stick with me. So I'm going to cover some updates, a review of bipolar, and then sort of update some of the newer pharmacotherapy that's out there as well. So what is bipolar? It's a psychiatric illness, of course, that's characterized by those intense changes in mood and behavior and thought and energy levels. And patients go through multiple episodes and behavioral patterns over time, and those are termed those episodes. So these include the major depressive, manic, mixed, and hypomanic episodes. And we'll define those a little bit further in a minute. The combination of how a patient experiences those episodes is what determines what subtype of bipolar they have. And so there are 4 different types: bipolar 1, 2, there's cyclothymia, and then bipolar not otherwise specified. Very creative and a catch-all. So what are the episode criteria? So I'm not going to go through all of this, it would take a while. But for major depressive, patients have to have at least 5 of the following symptoms during a 2-week period. So these are things that you would expect to have to experience to be diagnosed with some sort of depression. So do you have diminished interest or pleasure in your normal activities? Have you lost weight or gained weight? Changes in your appetite? Trouble sleeping, or maybe sleeping too much? Recurrent thoughts of death or suicidal ideation or suicidal attempts? Manic phases are sort of the opposite, so elevated or irritated mood for at least a week. And so they have to have at least 3 of the following symptoms. So grandiosity, meaning patients think that they have this importance that perhaps maybe they do not. They claim fame in some way. They have a decreased need for sleep. Patients are often up. Actually, if you YouTube manic phase of bipolar, people actually record themselves during a manic phase, and they're up all night, and they talk the whole time. They have pressured speech. There's a flight of ideas and racing thoughts. Often when patients are manic, this is when you read in an HMP that a patient was in Florida, they took a bus all night, they hitchhiked, they're in North Carolina, they've been gambling, they lost all their money. That's usually a manic phase. Hypomanic is a little bit different, so it's an elevated or an irritable mood for at least 4 days, but that mood has to be different from their usual non-depressed mood. So it's not quite as severe as a true manic state, but it's also not quite the same as a normal state. It's an obvious change in functioning that has to be observable, but not severe enough to markedly impair their functionality or to require hospitalization. Then mixed states would be symptoms from, of course, major depressive and manic for at least a week. So putting those episodes together, how do they fit into the subtypes? Well, the classic bipolar 1 would be a mix of manic or a mixed episode with or without psychosis and or major depression. So very high highs and very low lows is kind of how that's classically described. Bipolar 2 is a hypomanic episode, so not quite as high of a high, but still with major depression. Cyclothymia is sort of in the middle, so cycling through hypomania and depression, but not major depression. And then not otherwise specified is, again, a catch-all for symptoms that don't meet criteria of the other subtypes. So if you're like me and you're a little bit more visual, this is kind of a visual description of those types. And so you can see, good, I have a mouse. You can see bipolar 1, you have the very high highs and the very low lows. Bipolar 2 in red, we have slight highs and still the lows. Cyclothymia is kind of in the middle, cycling through those, I guess, moderate states. And then not otherwise specified isn't on here because it's not really characterizable. So then, there we go. So why do we care about bipolar? I think one of the reasons that Jillian and I wanted to touch on psych is because it's these disease states are things that touch, I think, all of us in all of our practice locations. And I feel like sometimes they're a little bit less, we're a little bit less attentive to them than some of the harder hitting chief complaints that bring people in. But bipolar is the 12th most common moderately to severely disabling condition in the world in any age group. There is no clear association with any socioeconomic status, race, ethnicity, gender. Basically, it can crop up in anybody. The average age at onset is usually somewhere in the late teens to early 20s, but it can occur as late as the early 40s. So this is the truly, I think, shocking and distressing point, is that the mean time to seek treatment after people start experiencing symptoms is about 5 years. And then even more distressing is that the mean time to correct diagnosis is almost a decade. So that's really, you can imagine these patients are experiencing symptoms for a really long time without knowing why they're feeling the way they are. So that's truly, I think, just distressing. So 40 to 60% of people that are diagnosed as bipolar have a comorbid substance abuse or anxiety disorder. And 1/3 of bipolar patients attempt suicide. So that's 20 times higher than the general population. So again, this is why I think we need to work on, I think, being more attentive, and we being the healthcare population as a whole, being more attentive to some of these psychiatric issues. So why does bipolar happen? So basically the little smiley face sort of sums it up. We don't really know. There are all these really neat hypotheses out there for why this might happen. One of the most popular ones is the catecholamine hypothesis, meaning if you have high levels of our catecholamines, like norepinephrine and dopamine, that can contribute to a manic state. If you have low levels, then that's your depressed state. Unfortunately, it doesn't really explain everything. One of the other, I think, most interesting ones here is the electrophysiological kindling syndrome. And so this is where they found that there's an association with the fact that people with later episodes don't have as many triggers as when people have earlier episodes. So it seems like once you start down this road, you may or may not really need a trigger later on. It may just happen. And so that is why they call it the kindling syndrome. Like Jillian discussed, genetics are more of a I guess, piece with bipolar disease than with depression. So definitely can have some associations within family lineage. In terms of how bipolar patients present and their diagnosis, they often present in a depressed or a mixed state. And so a mixed state meaning they're depressed, but they have high energy levels. And so this is when the risk of suicidality is very high because they have the energy to do it and the mood to not feel like wanting to go on. There are questionnaires available to help us diagnose or to help the psychiatrist diagnose. They do have a high negative predictive value, but not such a great sensitivity, so the positive predictive value isn't fantastic. As pharmacists, it's important for us to think about ruling out other causes of symptoms, including drug abuse. So is your patient on amphetamine? Is your patient a cocaine abuser? Other medications, are they taking steroids? Are they on bromocriptine because that's a dopamine agonist? Disease states, are they hyperthyroid? Is that why they feel so jittery and they have so much energy? So it's important for us to think about everything in the picture before we go down the line of definite bipolar. So in terms of treatment, I just wanted to list out, I was doing this presentation and making it, and I started looking for what are the latest treatment guidelines. And I want you to know that this is what I found initially. I was like, why did we choose bipolar? So as you can see, there's been a plethora of different groups that have come up with treatment guidelines. The last update from the American Psychiatric Association, and really the latest update from this group, was in 2005. I was like, oh my gosh, am I doing updates in bipolar and I'm using a guideline from 12 years ago? A little sad. So I was kind of like, oh my gosh, help. Thank you, Britain, because finally I found somebody had gotten the gumption to put something together in 2016. And so this is the guidelines that I will quickly review in terms of treatment. When we're looking at these guidelines, I want you to just kind of pay at least some attention to the evidence categories as well as the grade of recommendation. So the evidence categories range from 1 to 4. We would love to see lots of 1, so that's your high level of evidence. In terms of grade of recommendation, we want to see lots of 4 stars. That's a high level of recommendation. S is for standard of care. So not that you have to remember all that, just remember we want 1s and we want 4s. So when we look at the treatment for acute manic or hypomanic episodes, these 2016 guidelines broke it down into whether the patient was treatment naive, whether they had some history of being treated for mania or hypomania, and then whether or not the patient requires adjunctive therapies. And so for naive patients, they gave a high recommendation to Haldol, olanzapine, risperidone, and quetiapine. I want you to notice that there is no level of evidence grade on this. That's sort of just going to be a theme throughout, that there's really just not much evidence associated with most of this. Second line for treatment naive is valproate, and third line would be aripiprazole, carbamazepine, or lithium. For treatment experienced, as you would expect, the first thing that they want you to do is to make sure that the current therapy has been optimized already. Is the patient actually taking their medications? So, of course, medication adherence in the psychiatric population is often an issue. If you have established those pieces, then they recommend utilizing some combination of lithium plus either valproate or a dopamine antagonist, which would be an antipsychotic. After that comes clozapine, and finally electroconvulsive therapy. In terms of adjunctive therapies, they recommend benzodiazepines as needed for agitation or insomnia. And then they say, and I want you to log this away for later, consider tapering off of antidepressants because of the risk of potentially worsening mania or switching into mania or hypomania once you get them controlled. So that's for acute mania and hypomania. So then for acute depressive episodes of bipolar, again, they delineate out, is the patient treatment naive or have they had some experience? So for treatment naive patients, the only FDA-approved therapies for acute depressive episodes are quetiapine, lorazepam, and olanzapine. And again, it's sort of not even a high level of recommendation, it's sort of a mild level. So a little bit tough. On an equal plane with that, they also say that you can use lamotrigine plus some other anti-mania medication, whether that is lithium or others that we will talk about. Interestingly, fluoxetine and olanzapine is also recommended, and so it's interesting on the mania section, they say consider tapering off of antidepressants. Then if you have an acute depressive episode, well, we need to get you out of that, so we need an antidepressant, but we don't necessarily want to use that alone, so we'll combine it with olanzapine. And so we're going to address that a little bit more later. Interestingly, too, they do say that certain antidepressants have more of a risk of switching to mania. Fluoxetine is the one that's recommended. We definitely would not want to do things that have mixed serotonin and norepinephrine action. So things like venlafaxine, desvenlafaxine, duloxetine seem to have a higher risk of switching into mania. So if you're going to do it, they recommend potentially fluoxetine instead. After that comes our usual antidepressant plus a mood stabilizer like lithium, valproate, or dopamine antagonist. So for treatment experienced, they recommend the same thing, optimize their current therapy, and then utilize combinations if need be. So then in terms of maintenance therapy, so once you pull them out of their acute issue, they say that we should continue therapy indefinitely as long as the patient is tolerating because there's such a high risk of relapse for these patients. There's marginal evidence for most long-term pharmacotherapies. If you're going to choose something, there's the most evidence with lithium and the least evidence with carbamazepine. Lithium can be considered as initial monotherapy. There's not really great evidence for differentiating between bipolar 1 and bipolar 2 in terms of this treatment, so they do recommend just extrapolating information from bipolar 1 to bipolar 2. Address the symptomatic anxiety or agitation with short-term adjunctive therapy, so that's very similar, making sure that we're addressing any concomitant substance abuse disorders, and then making sure that if we do one day achieve remission, we wouldn't just pull these drugs away. We'd want to make sure that we taper them slowly over the course of at least 4 weeks. So now we are going to move into some pharmacotherapy, and I want to put a little disclaimer on this. I'm going to shove a lot of information up here because I wanted you to have it available. What I want you to take away from this is if you get an order in the queue for one of these medications, what are the safety issues that you should be thinking about? Efficacy is such a toss-up because it's so much trial and error that I feel like we have a hard time delineating out what might be efficacious. So try to take away some of the safety information. So first I want to go through some mood stabilizers, and so the first one of these is lithium. That's sort of our classic bipolar medication. In terms of how it's dosed and what we're looking for, we do measure troughs with this. We typically wait about 5 to 7 days after initiation or a dose change to check that level. For acute mania and really maintenance, I sort of always just remember the same range. I think of 0.6 to 1 and maybe let them range up to 1.2 if they're severely manic. Toxicity occurs at levels greater than 1.5. And so what is toxicity? Because sometimes we don't have levels available in our EMR. A patient comes in, how do you know if perhaps lithium is contributing to some of their symptoms? Well, greater than 1.5, the first sign of toxicity is that they develop a tremor. It may also be nausea or diarrhea. They can have confusion or decreased reflexes. Above 2.5, we get into the range of potential for seizures and arrhythmias and permanent neurological damage. Hopefully you're not seeing these signs in your patient. And finally, above 3.5 is when you get into potentially lethal levels. So how do we avoid getting to toxic levels? We need to make sure that we monitor renal, cardiac, and thyroid function. Not so much thyroid for safety, but lithium can cause hypothyroidism. For renal function, lithium can cause nephrotoxicity. And so up to 20% of patients who are on lithium with time may actually develop chronic kidney disease. And is related to the patient's age, their cumulative dose, and the duration of treatment. So you can imagine sort of a cycle. If a patient gets into renal dysfunction, all of a sudden they may accumulate lithium to an additional degree. Lithium is also directly toxic to the myocardium, so we need to make sure that our patients have monitoring for that. Sodium and calcium levels. If patients are hyponatremic, that can actually predispose to lithium toxicity. So if you go back to your basic chemistry, lithium and sodium are in the same part of the periodic table, so they look very similar. So if your patient is hyponatremic, the kidney says, oh my gosh, I need to hold on to sodium. And it starts holding on to everything that looks like sodium, including lithium. This is very common, or patients can be more predisposed to this, especially in the summer when they're dehydrated. And so we have to really counsel them on that because they're losing salt through their sweat. So in terms of drug interactions, of course, it's always important. Two big ones that I think about are ACE inhibitors and angiotensin receptor blockers. We don't know the exact mechanism, but we think it has to do with the fact that those medications can cause some hyponatremia, which then leads to that holding on of lithium. The same kind of goes for alterations in sodium with NSAIDs, so we have to be careful with those. So then the next mood stabilizer is valproate. The main thing that I want you to take away from all this mess of dosing formulations is that IR is not equivalent to DR, and DR is not equivalent to ER. So they are not all bioequivalent. IV to PO is 1-to-1. So you're on the floor, your patient becomes NPO, they don't have enteral access. They were on 2,500 milligrams at night of Depakote. Well, what do I do now? You would take that same total daily dose and just break it up normally as Q8 for the IV formulation. So that's the main thing that I want you to take away from that. In terms of monitoring, again, we monitor troughs. This therapeutic, quote-unquote, level is not really for bipolar. This is more of a safety measure to make sure that we're not exceeding what would be safe for a patient, and it comes from our epileptic patients. So typically efficacy is just determined by clinical effect. Safety would be determined by checking this level. There is an increased risk of toxicity over 110, but some patients can tolerate it a little bit higher, up to the 125 mark. So what would that toxicity look like? CNS depression is definitely a big one, as well as abnormalities in liver function. Valproate can cause a hyperammonemia, which again would lead to encephalopathy and CNS effects. Of note, the quote-unquote antidote for that is levocarnitine, so just log that away. It can cause dose-related thrombocytopenia. There are tons of drug interactions with valproate because of its CYP3A and metabolism, as well as it's highly protein-bound. This is a known teratogen, so if you have a young lady of childbearing age, it would definitely not be the drug of choice for her. So then next we have carbamazepine, which is our last sort of traditional mood stabilizer. Again, another anti-epileptic that has crossed into the psych world. What I want you to take away from this is sort of these pearls over here. So again, our target levels aren't really well established for bipolar. We're not checking levels to see if it's within range to treat bipolar. We're checking to make sure that it is safe. And so if a patient is not responding at a certain dose, we would check a level and see, is it okay for us to increase from a safety perspective, more from an efficacy perspective? So if we check, we'd like to see them between 4 and 12. If you get above 15, you're reaching, again, that toxicity level. So what does toxicity look like, or what are some of the adverse effects of carbamazepine? Anemia, agranulocytosis, CNS depression. Of course, when you're initiating carbamazepine, we have to think about skin reactions like Stevens-Johnson, as well as hypersensitivity reactions. We should monitor liver function and sodium levels because this can cause hyponatremia. Tons of drug interactions. If you remember, carbamazepine is an autoinducer of its own metabolism because it's such an inducer of 3A4. And so what that means is when you check your first level of carbamazepine for a patient when they first initiate, and you're like, oh good, they're on their way, they're looking good. When you check the next one a week later, it may actually be low because it's inducing its own metabolism. So you may have to push through that, and hopefully eventually once you stabilize for 3 to 5 weeks, it will stabilize level-wise. Now if you change the dose again in the future, you may have to go through another autoinduction phase. Carbamazepine is also a known teratogen, and so it would not be a good choice during pregnancy. So, I'm going to take a drink. Y'all might need one too after all that. So we're going to move into the second generation antipsychotics, also known as the atypical antipsychotics. This is the best chart that I could come up with on the internet for including at least some of the newer agents. If you're like me, you're definitely familiar with like the aripiprazole and the olanzapine and quetiapine, risperidone, and ziprasidone. But since all of those were out, there have been about 6 more that have come out since then. And they are all a little bit different. So how do these drugs work? From this chart, as you can see, they hit and antagonize dopamine receptors, serotonin receptors, alpha adrenergic receptors in various amounts. And then some of them, like quetiapine and ziprasidone, have also been associated with reuptake inhibition of norepinephrine and serotonin, which is thought to contribute to their action. Aripiprazole is a little special, and it's not in this chart, but brexpiprazole and cariprazine are also in this class, where they are partial D2 agonists, which is thought to help modulate the amount of dopamine and hopefully decrease some of the EPS and tardive dyskinesia side effects while still allowing for antagonism for efficacy effects. So there's no way to remember all of this. Just know that they work in various amounts at different receptors and you get various effects because of that. So this is a little bit crazy, I know. But there was no good chart available for the side effects and adverse effects, including the newer agents. And so what we have here is a chart that I tried to combine from multiple sources to try and at least give us an idea of why that we have all these new medications. And so what we have is our typical adverse effects of our second generation antipsychotics, the list of all the available antipsychotics here with the newer ones highlighted in yellow. I didn't even know cariprazine existed until I was about 3/4 of the way through this presentation, so don't feel bad if you're like, what is that? If you see a plus minus on this chart, it means that that side effect is not particularly associated or it's minimally associated. A +3 means that it would be highly associated. And so, of course, the main side effects that we used to look for with some of the newer or some of the older atypical antipsychotics were a lot of the metabolic side effects that they were finding. So increases in lipid levels, increases in blood sugar, and definite weight gain. And so I think, hopefully y'all will see that for most of the ones in yellow, those adverse effects are more minimal than some of the older agents, especially like clozapine and olanzapine compared to the ones in yellow. So it's always a little bit of trial and error with our patients, but it's an individual basis as far as, is there anything we definitively want to avoid? Is the patient 300 pounds and their ideal is 180? Well, of course, we would want to avoid certain agents. Are they diabetic and their blood sugars are completely out of control? Or are we worried about orthostasis with them and we need to avoid certain agents that have a high risk of orthostasis? So this is, I would not take this as law. This is my interpretation of about 3 different charts, but it at least I think gives us an idea of why we have so many newer agents coming out. So then this is also a little bit of lots of info on one page, but I wanted to give you some pearls. What we're looking at here is, again, an alphabetized list of all of the available atypical antipsychotics, what formulations they come in, dosing schedules, and then some pearls about them. What I want you to know is that anything with a star has been FDA approved for bipolar. And so what I want to point out with that is that the only one that is approved for bipolar in a long-acting injectable formulation is risperidone. I will not say that that does not mean that they may not use other medications in the long-acting injection formulation for bipolar, but that's the only one that is FDA approved. In terms of some pearls with some of the newer agents, cariprazine or Vraylar has an extremely long half-life. Its active metabolite has a half-life of up to 3 weeks. And so even after 1 dose of that medication, it was still detectable for 10 days. So you can imagine if this is started on your patient and then they don't tolerate it, it's going to be there for a little while. So something to keep in mind. Clozaril, of course, we had the REMS program for reporting their neutrophil count because of the risk of neutropenia. Vilazodone must be administered with food. Let's see, there's the PO combination of olanzapine with Zyprexa is Symbyax. So remember, that's the one that is FDA approved for acute depressive episodes of bipolar. So they actually went and made a combination product to fit that bill. Interestingly, risperidone, if you get an order for the oral solution, it's not compatible with cola or tea. So if you get a question from a nurse about how can I give this to my patient, just make sure you don't recommend cola or tea. Go with juice. So a lot of very drug-specific pieces. So what I would want you to take away from this slide is just check administration instructions whenever you run across one of these. Because they are just very unique products. So I want to take you back to this question of antidepressants and bipolar. And so remembering that the 2016 guidelines said that there's a risk of a switch to mania or mood instability during treatment for bipolar. This risk can be increased by treatment with antidepressants as monotherapy. And if you decide to prescribe an antidepressant for somebody with bipolar, these patients have to be closely monitored. And so what does that mean? If I get a patient who's bipolar, like I did today, who's on an antidepressant, is it okay that they stay on their antidepressant? So there was a study that came out this year, it was published in the American Journal of Psychiatry, and it looked at this exact question. It was a randomized double-blind multi-center trial here, and they randomized people 1:1:1 to sertraline with a target dose of 100 milligrams per day versus lithium monotherapy, targeting serum levels of 0.8 to 1.2, or a combination of both. Follow-up was only for 16 weeks, so not terrible, but not fantastic. They did include adult outpatients with symptoms of depression, but they could not have any hypomania or mania according to the standard scales. let's see, the outcomes that they looked at, the primary outcome was how many patients switched to hypomania, severe hypomania, or just outright mania. And then also, of course, their secondary was safety, tolerability, and how many patients dropped out. So who were the patients, just so we can compare to ours? These were just under 40-year-old bipolar patients, mostly Caucasian, and they had had their illness for about 8 years since diagnosis. They did not give any information about what prior treatments the patients had tried, which I felt was a little frustrating, because that would have been very helpful. In terms of the primary outcome, they did not note any switches to mania, and there were no hospitalizations for hypomania, but you can see that they did have an increased number of patients who switched to hypomania in the sertraline monotherapy group. This was not noted to be statistically significant. The majority of switches did occur in the first 5 weeks of treatment, and in terms of what you're like, well, was there lithium therapeutic? They had a mean lithium level of either 0.61 in the responder group versus 0.51 in the non-responder. So just under where I would consider to be a therapeutic lithium, but definitely under their target levels in the study for 0.8 to 1.2. There was no difference in the number of patients who reached the target sertraline dose of 100 milligrams, so that piece also doesn't explain whether or not they missed something in the number of switches. So in terms of the secondary outcome, in terms of dropout rates, the main thing that I want you to take away here is that the combination group, when they were on lithium and sertraline, had a significantly higher rate of dropout than either monotherapy group. And this is shown here in this Kaplan-Meier curve, where the combination group is in green. And so the proportion remaining was much lower than the others with a p of 0.03. So if we look at why they dropped out and what were the adverse effects in the study, the significantly different effects between the groups, and I believe I cut off the top. This was lithium, this was sertraline, and then combination, I think was over here. This was a baseline. Sorry about that. So lithium, sertraline, and combination. So the significant differences were in thirst and urinary frequency, but I want you to take a note here that combination therapy had a rate of 23% of sexual dysfunction. And so if we go back to who are our patients, we've got young patients who probably were not very happy about that adverse effect. So the authors concluded that all 3 treatment arms were associated with equivalent switch rates. The lithium levels less than 0.6 seemed to be associated with an increased risk of switching, just as you would expect. That would be subtherapeutic. And that monotherapy had less discontinuation than combination. Personally, when I look at the study, I think it's a little bit difficult to interpret equivalent switch rates, since the mean lithium levels were kind of on the lower side in both of the groups. There was a limited duration of follow-up. It was only 16 weeks. I do think it does help us to see that maybe combination therapy with an antidepressant should not just automatically be ruled out in our bipolar patients. We just definitely would need to have increased monitoring, especially in the first 1 to 2 months, given the dropout rates. So, Pharm to the rescue. Meet IJ. He's my favorite person to save. He's a 38-year-old male. He comes in for shortness of breath and abdominal pain. He's got a history of bipolar 2. He has PTSD, probably from running from a rolling rock, hypertension, and a surgical skin graft. He takes lithium twice a day, which he started 3 weeks ago. He also has a couple antihypertensives, hydroxyzine, and then he has PRN ibuprofen. Nothing superbly exciting for his pulmonary exam other than some wheezing, and he had some nausea and diarrhea for about 2 days. His renal function is at baseline with a creatinine of 0.8. His sodium is 130, and his blood pressure is fine. And so when reviewing his chart, you see in an outpatient PCP note that he received a new script for lisinopril 10 once a day 1 week prior to admission. And so what is your next step as the person reviewing this patient? Derek's saying it. So we would want to check the EMR and see, do we have any lithium levels for this patient? He recently started. Hopefully it's been checked at least once or twice. We want to assess and go talk to IJ and ask him, how much are you using that PRN ibuprofen? Is this something that you're taking once a week, or is it something you're taking 3 times a day because of that interaction and risk of toxicity with lithium and NSAIDs? We would want to contact the physician and recommend holding that lisinopril for that same risk, ibuprofen and lithium, and we need to go ahead and get a level because our patient's nausea, he's been nauseated for 2 days, which is definitely one of the first signs of lithium toxicity. So they draw his lithium level in the ER about 10 hours after his morning dose, and it returns at 1.8. His lithium order remains inactive, and psych is consulted. And basically, psych says, he's got thoughts of self-worthlessness, he has a lot of depression that's interfering with his normal activities, he finds little pleasure, he's lost some weight, basically just experiencing symptoms of depression. And so he's being treated with a course of ceftriaxone and azithro for his newfound community-acquired pneumonia, but his EKG is pretty normal with a QTC of 440. So at this point, and I'm curious to see what y'all say, which of the following would be the best therapeutic option for IJ? I'm not going to lie, this one's a little harder. I was torn on it myself and I wrote the question. I wanted to see what y'all's thoughts were. Anybody want to take a stab? So I thought I might initiate quetiapine. So I heard 1E. So that's the other one that I would consider is potentially starting sertraline. So if we walk through these one by one, according to the guidelines for people that are treatment experienced, we would want to make sure we optimize current therapy. Well, clearly his lithium is high. We wouldn't want to abandon it yet, but we would want to continue to work on that. He is experiencing symptoms of depression. Quetiapine is one of the FDA-approved medications for acute depressive episodes. Starting dose for bipolar is 50. So B is kind of out because that's one of our target doses. We wouldn't want to initiate at 300 milligrams. C is out because his level of lithium is 1.8. We wouldn't want to resume that just yet. Maybe down the road, not yet. D is the other alternative because of that study showing that maybe the switch rates to mania or hypomania aren't as high as we initially thought. And so that would also be something that I would consider, but I also don't know that we necessarily have enough evidence to recommend it, especially in somebody who is 38, travels the world, likes to flirt, may not be the best option. So, an alternative. And so, what questions do you guys have about either depression or bipolar? Thank you for your patience. I know we had a lot of information.
Which one of those depression meds are unfamiliar?
That's a good question. I don't think any of the 3 new ones are.
Okay.
But I can clarify.
You just mentioned like unverified orders with her.
Oh, I'm just saying for non-form. We do get, a fair amount of patients, and I feel like I never want to discontinue their whole antidepressant. So,
Yeah.
that would just be something to look out for.
Anybody else? Yeah.
Thanks for talking about a very difficult and broad topic. My question is about the various studies that are out there, not only with the new antidepressants for both bipolar and all the other drugs that are for bipolar or depression, but the older studies had showed a significant placebo effect as well. And either of you speak to, you can just talk about one, depression or bipolar, but there seems to be a significant placebo effect when looking at these drugs, where a lot of these trials look for statistical significance, but maybe not mentioning or pointing out clinical significance.
Yeah, I think that's a good Wait, I can pull back. Well, I don't know what I just did. Let me go to some of the slides. I question that with some of the new trials, especially this one, because really the effects really aren't that different. And let me pull it up really quick. Between the vortioxetine and placebo. I mean, if you look up there, you can see that the black is going to be the placebo. And you can see even at like 8 weeks, I mean, there's still a significant change in symptoms. So I think it's difficult to interpret. And the other thing is that a lot of these studies are only 8 weeks long. So how do you interpret long term whether this would lead to changes in depression? But I agree with you. There is a big difference in placebo, and potentially you do see a large effect. So there still is a pretty significant difference between placebo and duloxetine as far as questions go, but maybe not as much as, how do you even interpret that, I think is difficult because a lot of the questions are also very subjective too. So.
Somebody else. Thanks for coming. Really, thanks for sticking with us and our mad dash to do both.